I am speaking today a special scenarios and tips to avoid complications of thyroid surgery. Uh, I know in routine our day-to-day practice, in addition to getting straightforward, simple thyroid neoplasm, sometimes we come across very complicated, very difficult thyroid tumors, very advanced tumors. In such cases, I just like to share some of my experiences to how I have managed and how we can avoid complications and what clues that we have to take. That's how I am going to present. It needs, of course, to avoid complication, we need a detailed evaluation of each and every patient. A careful planning is very much required. Detailed counseling is also very, very important. For example, detailed evaluation. As a clinician, as soon as the patient comes, we have to evaluate the patient. What is the size of the tumor? Is it involved one side or both sides? Is there any presence or absence of lymph nodes? Is there any fixity? Is it moves with the deglutition? Whether is there any suprasternal extension or mediastinal extension? See, all this evaluation is a clinical evaluation added with the radiological ultrasonography. Of course, if needed, we can do an endoscopic evaluation, even including bronchoscopy if you suspect a disease in the trachea, and of course, other routine evaluation is very important. After knowing the diagnosis, careful planning is very important for each and every clinician. How we have to approach this type of advanced cases? Whether, as we had discussed in the morning, whether we have to go in a midline or lateral approach is very, very important. In such advanced cases, probably midline approach is impossible. We have to come from lateral to medial, and doing neck dissections is whether is required, whether is there any need of sternotomy or not. We have to have ideas in advance. For example, detailed counseling is very, very important. Even once, twice, we have to make the patient attendance. What is the amount of disease that he is having? What is the stage of the disease? And what are the likely complications that we can encounter? So we have to do a detailed counseling regarding the need of radioactive iodine ablation, poor prognosis, need of tracheostomy sometimes, need of sternotomy, and lifelong thyroid replacement. All these things we have to take a, and recurrent longitudinal paresis, paralysis, all these things we have to document. For example, some of the cases which I have come across, I just like to share. For example, this patient aged 45 years, patient is asymptomatic. When somebody is recommended ultrasonography neck for the investigation of fever, they found out some hypoechoic nodules involving both lobes of thyroid with extensive retrosternal mass extending from the right lobe. So these are the routine investigations, and X-ray, neck, AP and lateral view. This is the CT scan. You can see a tumor extending from the right lobe thyroid till the mediastinum down. It is not a very extensive involvement. It is the tumor is nicely encapsulated. So in this scenario, whether we have to approach transcervical approach or a sternotomy approach, or we have to keep a thoracic surgeon standby is very important. Most of such cases, a moderate extension to the substernal area. Most of the cases, if we get a good cleavage like this, we can, after getting a good cleavage, separating the major vessels, if you insinuate, if you through the finger carefully without creating bleeding, one can deliver this type of tumors. Most of such tumors, see here, that's how I have operated in this case. So we have to take care of recurrent longitudinal. Of course, I have done a total thyroidectomy like this. This is the substernal ectopic thyroid. So in such cases, of course, a beginner, even an experienced person may get into mind whether sternotomy is required, whether it will come out easily or not. In fact, this patient is wife of an anesthetist. I have kept a thoracic surgeon standby, though he is not required. For example, in another case, a female patient aged 50 years, she had a 10 years of history of thyroid, no symptoms, no other clinical symptoms, firm to hard mass involving the right lobe thyroid, 4 to 4 centimeter. It was not moving on deglutition. The tumor was extending up to the clavicle. This is how she presented. Ideally is normal. These are the investigation, routine investigations we have asked. So you can see a substernal extensive mass from the thyroid. This is how the MRI and findings we could see the tumor extending down to the mediastinum up to the cardiac. So if you get this type of cases, though it is benign, whether we have to keep a thoracic surgeon, whether he needs a trans sternal approach, midline trans sternal approach, we have to keep in our mind. When compared to earlier case, this case is very extensive. I have told them, I did a detailed counseling to the patient attendants that she requires a sternotomy, and then we have to go ahead. So this is how the neck procedure I did, and our cardiac thoracic surgeon, Dr. Ganesh Naik. You could see after removal of this tumor, there is a fixed tumor. We attempted to pass our finger, nothing, it has moved. See, this is the tumor. Then we took the immediate decision of midline sternotomy. In fact, Dr. Ganesh Naik is a very senior thoracic surgeon. We did together, and then we separated the tumor from the great vessels of the superior mediastinum, especially innominate vein and the other arteries, and we could deliver. This is the mediastinal tumor. So why I have presented this case? See, in most of the cases with a moderate, nicely encapsulated tumor, moderate extension, retrosternal extension, we can deliver to the neck. But this type of cases, we cannot deliver. We have to do a sternotomy. That's the reason why I have kept this case. In another similar case, it's a malignant case. The previous case is a benign case. It's a papillary carcinoma, very advanced, long-standing. Patient had a stridor. In fact, he was not able to walk for a small distance. That's how he presented. In fact, see, this is the neck procedure. I could do the entire neck is covered with a tumor. And our thoracic surgeon, see, this is the amount of tumor which is extending up to the perichondrium. We could remove. See, that is the tumor from the mediastinum. He is Dr. Ganesh Naik. I just want to show you. So definitely this particular case requires, and later on this patient, after good healing, in fact he didn't have any symptoms. His respiratory distress has reduced, he could able to swallow, his speech was very good. I did a total thyroidectomy. So this is how we have to take care. So for example, this patient, 20 years back, she has underwent a thyroidectomy for a benign lesion. And she kept quiet for a long period. This is how she presented to us. And I evaluated in detail, I asking CT scan, MRI, this is how she presented. See the trachea, how much narrowing, even though she didn't have a stridor. In fact, I was worried there any difficulty in intubation itself. You can see the trachea, how much it is pushed anteriorly and in between the thyroid masses on either side, even though it is benign. So I discussed in detail with them. Then I did a surgery, bilateral radical neck approach. I did a bilateral radical neck approach. I could able to deliver the tumor, even though it is a benign, it is encapsulated. Only, of course, we have to have a patience, and we have to do very slowly, meticulously to remove such tumors. So one should have a carefully planned these cases, starting from detailed counseling regarding the morbidity and the risk involved. Starting from intubation, we have to discuss with anesthetist. In fact, prior discussion with the anesthetist is very important. Whether they can intubate, is there any risk of doing tracheostomy? Definitely there is a high risk. Even to the patient attendants, we have to do a counseling. It is possible to do a successful surgery in such cases. For example, this locally advanced papillary carcinoma, 5 years, he had a vocal cord paralysis. He went to an ENT doctor. During that time, he could not palpate any thyroid lesion. 5 years back, he said it is a what is that? Idiopathic. He said idiopathic paralysis. He didn't evaluate it. Then he kept quiet at home. After 5 years, he has come with a neck mass. This is how he presented. You will be surprised if you see a extensive mass. See, no, this is how he presented. This is the tumor infiltrating the suprasternal knot. It's almost a fixed mass, totally fixed mass. And he had a bilateral neck node. Right vocal cord was paralyzed. This is the tumor. I was worried whether I am able to resect it without injuring vessels or without sternotomy. Then this is how, see, total plastering of the disease. This is how he presented on the neck. And I did a bilateral R&D approach. I did R&D and clearance of the suprasternal knot. In fact, I have advised sternotomy, the risk of tracheostomy, because he already had a right vocal cord paralysis. In fact, I took consent for the tracheostomy, consent for the suprasternal, sternotomy. But at the end, it is the recurrent lesion of contralateral side I could able to preserve nicely, including parathyroid. I thought God is very much mercy in providing this nerve, at least avoiding tracheostomy. And then at the end, this is the type of resection I could able to do. And I avoided tracheostomy, avoided sternotomy. We gave a radioactive iodine ablation. More than 11 years, still he is doing nice. In fact, to be frank, yesterday this guy has come. After 3 in the morning, I told, after 3.5 years, he has not come for follow-up. Now, on clinical evaluation from a distance, I saw there is a disease in the over the trachea and in the supraclavicular area, supraclavicular region. Probably I am going to do a re-thyroid surgery along with the thoracic surgeon again. Whatever best I wanted to, and he is hale and healthy otherwise. This is a similar case, advanced papillary carcinoma. He had a fixed mass. It was proved papillary carcinoma. That is this how I see. Sometimes we may have to do radical neck dissection. In fact, after ligating internal jugular vein, I could not get it common carotid. I have cut open the tumor, and then they delivered the carotid artery. This is the edematous vagal nerve. Initially, this patient had a change of voice, but gradually after some 6 months, now his speech is very much normal. He's still doing very well. He received radioactive ablation. This is another patient, a very interesting case, 20 years history of duration, and he went to an orthopedic surgeon with iliac bone with a limping. He was not able to walk. a mass in the iliac region. He went to an orthopedic surgeon. They did a true cut biopsy and then proved as follicular carcinoma metastatic to thyroid. Then at that stage he presented to us. That's how he has come to us. And of course, after routine evaluation, he had a multiple. This is the MRI finding. You see the trachea how it has pushed even here, and unfortunately he had see the trachea how it has pushed. Unfortunately, he had a multiple bony metastasis, including iliac crest, the the spine, and even the rib. He had a multiple bony metastasis. In fact, I did a surgery. This is how I did the surgery. Of course, I took 5 6 hours. It was very hemorrhagic. Dr. Santosh, one who endocrinologist who gave a talk just he had in fact this patient had a thyrotoxicosis before surgery. He brought him to euthyroid and then we operated. In spite of good surgery and avoiding thyroid hormone replacement for a period of months, TSH level has not raised because of active release of hormones from functioning metabolic bony lesion. This was the symptom that we had. Then we were forced to give a radioactive ablation. In spite of that, we waited for 1 month. The TSH has not reduced because of the active release of. Then he responded very well. This is the nuclear medicine photo, and this is how he is doing well. He is speaking now, no limping. He has responded very well. Almost 3.5 years, he is doing very well. This is another interesting case, a vocal cord paralysis. 5 years, they did not bother. They came with a neck mass. This is how we presented. And after investigation, it was proved to be a papillary carcinoma thyroid. And then this is the MRI, CT scan MRI finding. In fact, you can see a tumor, extensive long-standing tumor, going underneath the larynx, under the membranous part of trachea to the opposite side. In addition to this lobe, this is how he presented. He also had a vocal cord paralysis. This is the X-ray neck lateral view. In fact, it is one of the very interesting case. I thought of, I gave 3 options to this patient. One, preserving the opposite nerve, because one vocal cord was mobile. Whether I can able to preserve his larynx. Whether I am able to do a total thyroidectomy with preserving larynx. That one option I gave. Second option, probably patient needs a total thyroidectomy and total laryngectomy also I gave. I gave an option of even gastric pull-up. He had such an advanced disease. All the 3 options I gave, I took a consent from the patient. In fact, I went on the opposite side. You can see a recurrent lesion now. I preserved. In fact, this tumor is the tumor of the opposite side, not the same side. In fact, thyroid was somewhere here. Then I could not proceed further. Then I went on the ipsilateral side, a paralyzed side. Again, this is the, I went like an R&D approach. This is the paralyzed vocal cord. I have cut recurrent longitudinal. You can see a tumor infiltration into the trachea and to the larynx at this site. Then finally, I went once again outside and took a consent for a total thyroidectomy along with total thyroidectomy. I did a total laryngectomy like this. We had a disease adhering to the trachea as well as to the larynx. And this is the tumor. And he is, in fact, he is a bank manager. Almost 12 years, he is still doing very well. Insular variant of papillary carcinoma. That's the final HP report. And he is receiving radioactive ablation. And he is doing very well. Even now, he is doing very well. And he speaks electrolarynx for his communication. A similar case I did when I was in Kidwai, a laryngectomy for advanced patient with a, along with total thyroidectomy, is almost 12 years He was fine. Later on, he developed a recurrence at the esophagus, PE segment. I gave an option of pull-up, in fact, salvage pull-up, but they were very much against for that surgery. In fact, he is still having a disease at the esophageal level. In spite of operation twice, in spite of external radiotherapy, still is having a disease. And the reasons for the presentation of these cases, we do get such advanced cases, needed bilateral leg resection, total thyroidectomy, total laryngectomy, to the extent of laryngopharyngosophageectomy. It is worth operating in such advanced cases, followed by radioactive iodine ablation. In all these cases, preservation of parathyroids is utmost important. A word against undifferentiated CA thyroid. We have to be very careful. See, this FNAC was inconclusive in this particular case. By seeing the CT scan, we thought we can operate. This is how I have operated. In fact, I did R&D in this particular patient. See, this is how I operated. I did an R&D, and this is my final picture. I could able to do with the internal jugular vein clearance. This is how I really struggled 6 to 7 hours to clear this disease. In fact, I did very well. But she final histopathological diagnosis is a poorly differentiated squamous cell carcinoma. That was the report. Then I sent for radiotherapy, external radiotherapy. While receiving radiotherapy itself, patient developed recurrence, and she, of course, within short time she had succumbed. This is another differentiated thyroid. So in differentiated thyroid, we should be very careful in venturing our heroism. See, this is another interesting case. Because it is a this is the conference that we can. I didn't know whether I can speak this case or not. In fact, this is how patient presented to me. 3.5 months back, patient underwent a total thyroidectomy somewhere nearby, and she had a discharging sinus, repeated discharging sinus. Wound has not healed. This is an abscess that previous operating surgeon 2-3 times he has drained. He did a drainage. Still, it has not healed. Then they were fed up and they came to me. Then by MRI and CT scan showing a residual disease in the thyroid, and I was thinking how to go ahead about this patient. Then I thought of doing a revision thyroidectomy and excision of the discharging sinus tract. That was my thinking. Then on the table, till the end, we could not made out anything. I thought even before seeing this, I thought there is a disease, hard mass was there in the thyroid lobe. Then one of my assistants said, "Sir, there is some cloth is there." Then we came to know, we removed this. Of course, I was worried whether it has got any communication to the pharynx. Fortunately, there was no communication. There was a thick walled cavity was there, and then I removed this cos piece. This is also just like that. I thought of showing this particular case. This is another interesting case. In fact, an advanced medullary CA thyroid mainly involving left lobe, measuring 6 by 6 centimeter, pushing the larynx and trachea to the right, with the right vocal cord paralysis, with moderate respiratory distress, awaiting for the surgery. In fact, I was supposed to operate on this patient, thinking of doing a total thyroidectomy, and of course, one vocal cord was paralyzed, taking the risk of the opposite nerve preservation and ablation. But of course, this FNAC report has come as medullary carcinoma thyroid. But next day night, she presented with a severe stridor, presented to casualty, and then our duty anesthetist intubated the patient with great difficulty, not at one stroke. They struggled. They could able to intubate the patient, and then she had a lot of aspiration. lungs became very bad after intubation and in the ICU. They could not give patient fitness for the proposed surgery. In fact, for 10 days they could not give. I used to ask them regarding the fitness, but they could not give. Finally, on 10th day, they gave a fitness, and after doing thyroidectomy, I could see a total sloughing of the trachea and the larynx. It is actually see the discoloration. This is how it has opened. I have not opened the trachea here. It was a total sloughing. Probably this is a total iatrogenic reason. The pressure probably is not monitored properly in ICU. And then, in fact, I went outside again. How to continue the procedure? I didn't know that this was the situation. I did a nice thyroidectomy, in fact, under R&D. But at the end, I could see this picture. Then I went outside and then discussed with them. I did a total thyroidectomy along with the thyroidectomy, total laryngectomy along with thyroidectomy. So this is how, but there was some suspicion here. The slough might have gone into the esophagus just above the stoma. So then I did a laryngectomy. She was fine, 15 days. Then after 15 days, she developed a fistula just above the, not at this level. She developed fistula just above the stoma, probably because of previous necrosis. Then she developed all sort of complication, and at the end of 1 month, this patient succumbed. I could not save her life. This is how I did a thyroidectomy and a laryngectomy. So in conclusion, in a difficult thyroid tumor, careful clinical, as I have already told, clinical, radiological, imaging, preoperative diagnostic evaluation is important. Careful approach to this patient after detailed counseling regarding the morbidity, the risk involved, the risk of tracheostomy, recurrent angioparesis, paralysis, hypoparathyroidism, the need of adjuvant therapy, and SOS external radiotherapy, including prognosis, should be explained. And in all, every attempt should be made to preserve recurrent angina. Every attempt should be made to preserve parathyroids. I think we discussed much in the morning. Success of these surgeries is complete clearance of the disease. Of course, the perfect preservation of parathyroids and recurrent angina is very important, whatever the situation. And in advanced cases, we may have to do tracheal resection with anastomosis. Of course, one of my colleague has done few cases. I have not done tracheal resection and anastomosis. And sometimes we may need to do laryngectomy, even a pull-up. Thank you very much for patience.
Thank you, sir, to compensate on the surgical stuff that we saw just now, as shown by Nanjundappa sir, because there was a lull in the afternoon. There were a lot of medical topics. So you are a lot more wiser now. Thank you very much.
Thanks.
Sir, fantastic talk. It was actually very humbling for me. Very difficult cases, very nicely managed and very nicely documented. So congratulations, that's a fantastic talk.
Thank you.
It's an outstanding talk. Just the repertoire of cases that you've done is brilliant. My question is, have you ever been required to do a pull-up? The reason I ask is because we've been told that mostly if it's DTC or even poorly differentiated, and if it's involving the esophagus or the pharynx, it's usually the muscularis which is involved and the mucosa can be spared. There is usually very rarely transluminal disease. So that's the question.
You are absolutely correct. In the second case where I have done a laryngectomy, where I have not taken consent for the pull-up. In fact, in a total laryngectomy and a thyroidectomy, you have to think of the position of the esophagus, whether esophagus is intact, whether entire muscular layer, even though they will not have dysphagia. If you do endoscopy, it will be normal. But this particular patient, he had a muscular involvement, muscular layer involvement. In fact, I shaved off the disease from the esophageal muscular layer, even though mucous membrane was intact.
That's what is usually.
Even though patient was lived for 12 years after ablation and after external radiotherapy, probably I thought myself, if you had undergone a pull-up, you would have survived much more
So
longer.
all these
See, in
patients you
fact,
showed,
this type of cases requires pull-up in some cases.
yeah, but all the patients you showed, they've had exceptional survivorship. So hats
Yeah,
off to
of course,
what you've done.
because it is thyroid,
Yeah.
unless the de-differentiation, see, while receiving radiotherapy, referring radiotherapy itself, patient develops
That's an
thyroid.
outstanding body of work. So thank you so much
Thank
for
you.
sharing this.
Thank you.